Good morning. Good morning, everyone. You're very welcome to this Building One Health Action under iNap 2 event this morning here in Farmleigh. My name is Laura Dooley. I work with the AMRIC team in the Department of Health. My colleague, Rosarie Lynch, unfortunately couldn't be with us today, but she does send her good wishes to us this morning. Along with my colleagues in the Department of Agriculture, Food and the Marine, I'd also like to extend a very warm welcome to the delegates joining us online this morning. I'll shortly welcome Minister McConalogue and Minister Donnelly to formally open the conference, but first some housekeeping. Please note that in the event of an emergency, your exits are at the back of the room, to the left out through the conservatory, and you can also exit out through the front door which you came in this morning. The toilets are also located out to the left and down on the left-hand side here. Tea and coffee will be served in the conservatory at our break. You're kindly requested to please keep food and drink in that area only. Lunch will be served at 1 p.m. In order to get to this, you'll proceed back through the front door which you came in this morning, and you'll be directed around to the right-hand side of the house from there. For those who've signed up for a tour at lunchtime, this will begin at 1:35. All those with a red sticker on their badge have been registered for this, and you're kindly asked to sit in the Arkle room for lunch, and again, direction will be given to you about that. If you have any questions throughout the day, please find anyone with a grey lanyard and we'll be happy to help you out. Just to note, we have had a change to our programme today. We're delighted to welcome Dr. Eimear Cook, Executive Director of the European Medicines Agency, as our keynote speaker later this afternoon. Finally, as I mentioned, our event is being live streamed and will be available as a recording afterwards. Now it gives me great pleasure to introduce Minister McConalogue, who's the Minister for Agriculture, Food and the Marine, to formally open the conference this morning. Thank you.
Thank you, Laura, and good morning, everyone. I'm delighted to be with you all this morning and launching this hugely important event, Building One Health Actions under iNap 2. And certainly there's few other places it would be better to be this morning on such a beautiful morning than what a wonderful location as well. And indeed to be talking on an equally significant topic of importance. The One Health concept recognises that by sharing the same environment, people, animals and plants that are inextricably linked and depend on each other for mutual health and well-being. As Minister for Agriculture, Food and the Marine, I see the connection between human and animal health as crucially important. Because we, our animals and the environment are so closely intertwined, what affects one can have a profound effect on the other. Today we will hear from scientific experts and hands-on practitioners, from farmers and from policymakers, each of whom has a crucial role to play in one of our greatest One Health challenges, antimicrobial resistance. Antimicrobial resistance is a major global public health threat and one that must be taken very seriously and one that we must take a proactive approach to. We have all heard of an otherwise healthy relation or neighbour developing an infection that does not respond to treatment, where the bacteria involved, like MRSA, have become resistant to the antimicrobials that 10 or 20 years ago would have cured them quickly. More and more often, people are getting sick and sadly sometimes even dying because the drugs simply don't work anymore. This is really, really worrying to all of us. We see the same kind of issues in animals, and the two challenges are very closely related. Antimicrobial resistance is truly a One Health challenge, demanding a collective, collaborative response. With iNap 1 launched in 2017, and now with an even more ambitious iNap 2, Ireland is taking that vital One Health approach to combating antimicrobial resistance. We're working across disciplines and across policy areas and taking integrated actions across human, animal and environmental health sectors. To keep us all safe, each of us has responsibilities in ensuring that antimicrobials remain effective treatments in human animal and plant health, whether we are involved in the manufacture, supply or use of antimicrobials. Therefore, having key stakeholders here for today's discussions is hugely valuable in our national effort to address this One Health challenge. The agri-food sector has a crucial role in addressing antimicrobial resistance by maintaining the highest possible standards in animal health, thereby reducing the need for treatment in the first place, and by ensuring that when they are needed, antimicrobials are used prudently. When it comes to combating antimicrobial resistance, the old saying, "Prevention is better than cure," is among our most powerful tools. Healthy animals don't need antimicrobials, and actions that prevent disease and optimise animal health are key to reducing antimicrobial usage. Ireland's National Farmed Animal Health Strategy, together with our biosecurity and animal welfare strategies, all underpin this priority of keeping animals healthy and well. Healthy animals are, of course, also more productive, enhancing both our profitability and the sustainability of our agri-food sector, Ireland's most important and significant indigenous industry, worth €14.2 billion to the country in 2020. Showing that the sector meets the highest standards of sustainability, both economic, environmental and social, can help secure our competitive advantage. Last summer, I joined with the Taoiseach Micheál Martin in launching Food Vision 2030. iNap 2 supports this strategy's ambitious vision to become a world leader in sustainable food systems within the coming decade. In January 2022, the new EU veterinary medicines regulations came into force, providing a wide range of measures to fight antimicrobial resistance and promote more prudent and responsible use of antimicrobials in animals. The new legislation highlights that as the clinicians and prescribers of antimicrobials, veterinary practitioners have a key role to play in promoting the responsible use of antibiotics. Farmers, too, have a fundamental responsibility to protect the health and welfare of their animals. So collaboration between vets, farmers and other farm advisory professionals will ensure the best possible health outcomes for animals, reducing the need to use antimicrobials. European countries have committed to reducing the overall sales of antimicrobials for farm animals and in aquaculture by 50% by the year 2030. Every country must play its part, and like other countries, Ireland will set an ambitious but realistic target. This is not about ceasing the use of antimicrobials. They are essential when clinically indicated. I want to ensure that vets and farmers continue to have access to effective antibiotics so they can treat animals when outbreaks of bacterial disease occurs, protecting animal welfare and even preventing the transmission of zoonotic bacteria. The iNap model is an excellent example of working in partnership within the One Health framework. Since its launch in 2017, all stakeholders have shown commitment, taking visible leadership in their own areas of responsibility by promoting and advancing initiatives that help to address the challenge of antimicrobial resistance. I want to commend the ongoing work of the Joint Interdepartmental AMR Consultative Committee and the iNap Animal Health Implementation Committee. I know this means a considerable investment of time and of effort by everyone involved, and I can assure you, and I know you know, it is time well spent. We have seen great progress since 2017, and now Ireland's second National Action Plan, iNap 2, sets out an even more ambitious roadmap, building on our early achievements. Today offers a great opportunity for all One Health stakeholders to share learnings from iNap 1 and look to delivering the common actions under iNap 2. Ultimately, One Health is a sustainable development agenda issue and will be critical in achieving the UN Sustainable Development Goals, such as good health and well-being, responsible production and consumption, and partnership. Learnings from the COVID-19 pandemic, both globally and nationally, have brought the reality of One Health into sharp focus more than ever before. I believe that we can build on our success in taking a truly integrated approach to antimicrobial resistance and start work together on other One Health priorities. I recently read that 3 out of every 5 new diseases in humans have their origins in the animal kingdom, and spread from animals to people often occurs because of the spillover effect caused by pressures on our environment. That, for the layperson, is hugely worrying. Zoonosis, diseases transmissible from animals to people, must be tackled with the same joined-up approach and commitment so evident in the iNap model. Finally, I want to thank all those involved in the organisation of this joint event, my own department's staff and colleagues from the Department of Health, who've worked together with support from the Environmental Protection Agency to ensure you have a thought-provoking and informative programme today. So thank you very much for taking the time out to coming here today, and I wish you all a very productive session. Thank you, and go míle maith.
Thank you, Minister McConalogue. We now have a short recorded message from Minister for Health, Stephen Donnelly, TD.
Good morning. I'd like to welcome you to this Building One Health Action under iNap 2 conference. I'm very sorry that I can't be with you this morning to jointly open the event with my colleague, Minister McConalogue. Today is about acknowledging the work under Ireland's first National Action Plan on Antimicrobial Resistance, iNap 1, and it's about focusing on the future under our second One Health National Action Plan, iNap 2. The World Health Organization has declared that antimicrobial resistance is one of the top 10 global public health threats facing humanity. It's also recognised as a top priority by the European Commission. The development and implementation of One Health national action plans are recognised internationally as important steps in the management of AMR. The publication of iNap 2 further demonstrates Ireland's dedication to meeting our international and our European commitments. Given the challenging nature of AMR, we've adopted a whole-of-government approach to tackling antimicrobial resistance. I'd like to take a moment to commend the leadership of Dr. Tony Houlihan, Chief Medical Officer, and Mr. Martin Blake, Chief Veterinary Officer, in the Interdepartmental AMR Consultative Committee. I'd also like to acknowledge the work of this committee. It has been fundamental in achieving a cross-sectoral process with specialist and expert input to deliver iNap 1 and to develop and implement iNap 2. It's important to recognise that under iNap 1, significant progress was made. It was made in surveillance of infections and prescribing antimicrobials, infection prevention and control, national clinical guidelines, antimicrobial stewardship initiatives, monitoring programmes and awareness. Now, obviously, I don't have to tell the people attending today that the last 2.5 years have seen unprecedented strain put on our health and social care services, on patients, and of course, on our incredible health and social care workforce. To all of you, I want to say a huge thank you for everything that you've done, for everything that you continue to do. It's been a hugely challenging time. And yet, despite the challenges, the work on antimicrobial resistance progressed, which is fantastic to see. As we all know, the pandemic brought the importance of infectious prevention and control practices right to the fore. The very quick adaptation to increased IPC measures, both in our health and our social care services, and more broadly across society, that wouldn't have been possible without the groundwork that had been laid as a result of iNap 1. The actions to reduce the spread of infection and disease under iNap 1 provided a crucial base on which we were able to build the COVID-19 response. I know HSE AMRIC colleagues are present today, and I particularly want to acknowledge all of you and your immensely valuable contribution on this front. Your leadership in the development of IPC guidelines, in the provision of educational webinars, in the support has been and continues to be of huge importance. The work of HSE AMRIC was central as well to NEFIT and to NEFIT's work on COVID-19 and the advice that it gave me, the advice that it gave government. I want to acknowledge the contribution made by the former HSE AMRIC clinical lead, Professor Martin Cormacan, in this regard. Professor Cormacan provided invaluable insight, invaluable support, not only to the work at NEFIT, but more broadly right across the HSE AMRIC programme of work. And I know his successor, Dr. Eimear Brannigan, is going to continue to provide really important, strong leadership and guidance on infection prevention and control now and into the future. Many stakeholders, organisations and agencies across all the One Health sectors have contributed to the development of iNap 2. I would like to thank you for your continuing commitment to the AMR agenda in Ireland, and of course there's still much to achieve. iNap has ensured we've made good progress, but of course this is a journey. It's a journey where I hope we will continue to see policymakers, regulators, stakeholders from right across the One Health sectors working collaboratively, working together towards our common goals. iNap 2, of course, is an ambitious plan. It sets a roadmap for all of us for the next 4 years. It does so across multiple sectors, and of course it involves collaboration between a great many stakeholders. But the potential scale of AMR means that ambition is needed. I know that work has already begun. Today provides the opportunity to further the One Health connections that have already been established. Antimicrobial resistance is a patient safety issue. Since 2018, more than €24 million has been allocated to support AMR and IPC activities. This includes the recruitment of 300 healthcare professionals. We are going to continue to work with our One Health partners to build on this progress under iNap 2. Together, we can realise the ambition of iNap 2 through working together to protect antimicrobials for the future. Thank you.
Thanks to Minister Donnelly. I have great pleasure now to introduce Chief Nursing Officer with the Department of Health, Rachel Kenna.
Good morning to everybody here in the room with us and to everybody that has joined us online. I am delighted to welcome you here this morning. I would like to begin by thanking you, the One Health stakeholders, for joining us here today to acknowledge both the achievements under Ireland's first National Action Plan on Antimicrobial Resistance, iNap 1, and the work currently underway under Ireland's second One Health National Action Plan on Antimicrobial Resistance, iNap 2. Farmleigh House provides the perfect venue for today to host the first One Health stakeholder engagement undertaken since the beginning of COVID-19. And I'm delighted to be here today on my own behalf and the work of the NPSO office in the Department of Health, but also on behalf of our Chief Medical Officer, Dr. Tony Houlihan, who had hoped to be here but has asked me to relay his apologies. Minister Donnelly and Minister McConalogue have already acknowledged some of the progress that has been made under iNap 1. I would also like to take this opportunity to reflect on what iNap 1 has delivered. Like most complex initiatives, its implementation has given us much learning and experience in advancing the AMR agenda. It's hard to remember sometimes after what we've been through over the last number of years that one of the biggest AMR challenges facing Ireland's health and social care services at the time of publication of iNap 1 in 2017 was CPE. As many of you will know or be aware, CPE, as a type of superbug, is resistant to many antibiotics. In response to the rising number of cases, a public health emergency on CPE was declared by the Minister for Health then on the 25th of October 2017, the same day as the launch of iNap 1. iNap 1 provided a roadmap to tackle AMR, and actions included enhanced surveillance, increased screening and the use of clinical guidance, new governance structures and a focus on implementation and monitoring. Using iNap 1 as a guide, we were able to work closely with the HSE colleagues to prioritise actions and interventions that have collectively sought to reduce the spread of CPE. Thanks to the enhanced surveillance and monitoring introduced, we now know that CPE cases have stabilised in recent years. CPE is now included in a suite of healthcare-associated infection indicators routinely reported by our healthcare services, and a key performance indicator on CPE testing of 25,000 CPE screening tests per month is regularly exceeded. This targeted response to the CPE public health emergency and progress achieved under iNap 1 was recognised by the European Centre for Disease Prevention and Control and the European Commission on their country visit to Ireland in October 2019. Together with our colleagues in the Department of Agriculture, Food and the Marine, we hosted a week-long visit from the expert team from the European Commission and the ECDC. This was the first time that Ireland had participated in the Commission's country monitoring visit programme on AMR, and I am really pleased to say we were one of the first member states to host this as a One Health visit, where human health, animal health and environment all participated. The report from the visit provided us with informed considerations and external expert feedback on what Ireland was doing well, but more importantly, the areas where we could improve our response to AMR. These findings are one of the foundations on which iNap 2 is built. The 5 strategic objectives in iNap 1, which provided us with a flexible and responsive framework and assisted and guided us in the management of CPE, were also really critical to the response to COVID-19. The work undertaken in 2018 and 2019 on infection prevention control, IPC, played an important role in our ability to scale up in 2020 when COVID-19 emerged. And IPC continues to be a key enabler of both COVID-19 and non-COVID care in our health services. I would like to echo Minister Donnelly's thanks to all of our health and social care workers. I also acknowledge the role of our colleagues here today from the HSE and the health regulatory authorities in responding to the COVID-19 pandemic. The actions in iNap 2 build on the achievements of iNap 1 and are cognizant of our experience within COVID-19. iNap 2 takes actions under the 5 objectives and seeks to drive further ambition and progress both within and across the objectives. And I agree with Minister McConalogue when he says it's ambitious, but I think that is absolutely necessary. Antimicrobial resistance remains a patient safety issue that impacts across the whole of society. A focus on people and patients was fundamental to the development of iNap 2. iNap 2's patient-centred approach, which is founded on integrated care in line with Sláinte Care, aims to enhance the delivery of safe, high-quality care and experiences to the patients and their families that use our health and social care services every day. Our health services have gone through remarkable changes and innovation since the beginning of the COVID-19 pandemic. Much has changed over the lifetime of iNap 1, but IPC and antimicrobial stewardship remain essential parts of safe patient care. iNap 2 will require all of us to continue to be flexible and creative in our thinking on how best to work together, both across and within the health services, but also across sectors with our One Health partners. The progress achieved under iNap 1 demonstrates the value of working together with the One Health approach. I would really like to take this opportunity to acknowledge and thank my colleague Dr. Martin Blake, Chief Veterinary Officer, and his team in the Department of Agriculture, Food and Marine, who have shown an unwavering commitment to the One Health approach to AMR since the establishment of the Interdepartmental AMR Consultative Committee in 2014. We really look forward to continuing to work with you and other One Health key stakeholders under iNap 2. We have achieved a significant amount with iNap 1. However, that was only the initial chapter in our quest to tackle AMR. iNap 2 will take us further along our journey, and it details our roadmap until 2025. It seeks to expand and further build on our response to AMR, while also including enhanced monitoring through indicators and deliverables. iNap 2 has 5 objectives, 15 One Health actions, and numerous actions across each of the individual sectors. It is only with the continued engagement of all of you, the stakeholders, that together we will be able to build on the progress made under iNap 1. There is still a lot to achieve, however, our greatest asset is all of you, the people who will champion and deliver these actions. On my behalf, and on behalf of our Chief Medical Officer, I would like to really thank you all who have joined us here today. I am confident that together we will build One Health action under iNap 2, and I hope that you really enjoy the day.
Thanks very much, Rachel. I'd now like to introduce Chief Veterinary Officer with the Department of Agriculture, Food and the Marine, Dr. Martin Blake.
Thank you very much, Laura. Really want to welcome everyone here today, and really am delighted to be here. As previous speakers have said, we're here today to reflect on the outcome from iNap 1 and the ambition we have actually shown in delivering and bringing forward iNap 2. I particularly want to thank the organisers, Laura, Rosario and the team, and also my own team within agriculture for actually putting this together. Events like this just don't happen. A lot of work goes into them, and I'm conscious there was a lot of stress over the last couple of days, so really thanks them very much. As others have said, AMR is a true One Health issue in the context of a broader concern about the engagement of environment, humans and animals, and the challenges that arise. So I suppose the whole of society approach to One Health is not new. I think we can reflect back on Hippocrates in 400 BC in his publication on airs, waters and places, which reflects the fact, which I identified that where you live and the environment in which you live impacts on your health. So this One Health whole of society approach fosters health and well-being. It addresses the collective need for clean water, energy and air. It deals with safe and nutritious food. It takes action on climate change, and it contributes to at least 7 of the UN Sustainable Goals. As Rachel has said, we had a visit from the ECDC and EU Commissions in 2019, and they commended Ireland for the approach they were taking with iNap 1. More recently, we'll see as well the development at international level, where the WHO, the FAO, the World Organization of Animal Health recently rebranded as WOAH, and the United Nations Environmental Programme are working together to establish a joint work plan to improve prevention, monitoring, detection and control and containment of zoonotic diseases, recognising the importance of building One Health capacity at international level. And I think the challenge then for countries is to take a lead from that and actually work forward. You will recall in the context of the template we used for iNap 1, we had five strategic objectives. They focused on improving awareness and knowledge of antimicrobial resistance, enhancing surveillance of antimicrobial resistance and antibiotic use, reducing the spread of infection and disease, optimizing the use of antibiotics in human and animal health, and promoting research and sustainable investment in new medicines, diagnostic tools, vaccines and other interventions. And there has been very good progress. In the animal health sector, under iNap 1, there were 54 actions. 22 were actually completed, fully completed within the time frame, and 26 have continued on into iNap 2, which currently has 71 actions within the agriculture and environment sector. So iNap 2 has expanded its ambition by moving into the equine, aquaculture and companion animal sectors, and bringing forward actions in those spaces. So expanding ambition through committed leadership and collaboration. A key focus in the animal health sector is to improve health. Optimising health and welfare through a holistic, multifaceted approach involving disease prevention and control, a focus on supporting better husbandry and farm management, optimum nutrition, biosecurity and vaccination, the advisory services, educational opportunities and participation in various EU-funded schemes. I think we have to reflect in the animal health and environment sector, responsible use is key to addressing AMR. Reduction targets are about promoting and supporting collective actions towards realistic and sustainable levels of use. I think we have to recall the objectives, targets are not objectives in themselves, but signposts along a journey, a way of guiding and measuring progress towards the primary objective, which is improved health without the requirement for antibiotics. Just to pick up a couple of other issues that are coming through, it's about collection and better collection and utilisation of data. Data drives evidence-based decision-making. It allows identification and promotion of best practice and target support to address less sustainable practices. It talks about the collation and interrogation of available data for different sources. This will drive better productivity, farm profitability and food security. Another theme is reducing the use of high priority, critically important antimicrobials. Currently available data indicates significant progress in relation to in certain classes over the last number of years. Since 2016, we have seen a 15% reduction in the use of fluoroquinolones and a 20% reduction in macrolides. Cognizant of the importance of colistin for human health, the animal health sectors in Ireland agreed to a voluntary ban on its use in animal health in 2020. As the Minister mentioned, we have our new animal vet med and medicated feed legislation since January, and this recognises the important role of the agri-sector in addressing AMR. It highlights societal expectations and underlying responsibility of all players. But I think as we approach this challenge, we need to be conscious that the issue is not about just solving a problem. I think, as Peter Drucker would have said, results are obtained by exploiting opportunities, not just focusing on the problem. And by focusing on opportunities, you have the opportunity to actually make positive difference and explore opportunities in other areas. I think we all agree now that the future will not be the past. By focusing on usage data capture, the availability of certain products of the high priority CIAs, differences in approach to metaphylaxis and prophylaxis, re-evaluation of certain productions and husbandry systems, questioning the future of in-feed medication, the rollout and better use of sensitivity testing, and also be conscious of consumer and marketer demands. So I think we reflect on this. This is a real global health threat. Antibiotics are a precious resource and we need to protect and preserve them for future generations. This requires local multi-sectoral actions. In the animal health sector, the primary response objective is to improve animal health and then, when deemed necessary, to prescribe and use prudently in a targeted manner. I want to acknowledge the significant contribution by the various stakeholders over the last 5 years, and we look forward to continued work within the animal and environmental sectors and across sector with our human health colleagues over the next number of years. So I hope everyone enjoys the conference and wishes well. Thanks very much.
Thank you very much, Martin. So I'm delighted now to open our first session, where we will welcome speakers from the HSE Antimicrobial Resistance and Infection Prevention and Control team. HSE AMRIC have responsibility for the human health operational aspects of AMR and IPC policy. And as Minister Donnelly mentioned already, HSE AMRIC were integral to the COVID-19 response and continue to provide leadership and guidance at a national level on antimicrobial stewardship and infection prevention and control. The contribution made by the HSE AMRIC team was also recently recognised at the Health Corps Excellence Awards, where HSE AMRIC were awarded Clinical Team of the Year. This morning we'll hear from HSE AMRIC Clinical Lead, Dr. Eimear Brannigan, HSE AMRIC Communications Lead, Audrey Lambourn, HSE AMRIC Senior Antimicrobial Pharmacist, Ellen Martin, and HSE AMRIC Director of Nursing, Josephine Galway, and all of them will be telling you about the various fascinating and important initiatives that HSE AMRIC have undertaken in recent years. So Dr. Eimear Brannigan has worked in infectious diseases as a consultant since 2008. Dr. Brannigan's focus has been on infection prevention and control, antimicrobial stewardship, and healthcare-associated infections, including outbreak management. Eimear was Deputy Director of Infection Prevention and Control in the Imperial Hospital Group in London and joined the AMRIC team in September 2020 as Deputy Clinical Lead and became the Clinical Lead for the AMRIC programme in May 2022. So I would like you now to please welcome Dr. Brannigan.
Good morning, and thank you very much to the organisers for the invitation for us to share and showcase some of our work today. It's exciting to be here at my first One Health in-person meeting for some time, and I'm looking forward to listening to the other presentations today and learning from colleagues across the sectors. This morning we are going to talk about some of our work primarily in two examples from work in the community sector, but that's not to dismiss at all the fact that we work across the acute sectors as well. So colleagues from acute sector and community sector are here this morning to join with us for this event, and I'm delighted for that. And then we also have some presentations about our work in communications and the work of our nursing team. So thank you. I hope you enjoyed the session. Let's see if I can get this to work. Yeah, great. So the work I'm going to talk about this morning builds, it's not my work, it's the work of the team, and it builds on what has been talked about already, iNap 1 and into iNap 2. And it's a quality improvement initiative for community prescribers. And the headline is that this has been involved our key stakeholders, the AMRIC and the HSE Primary Care Reimbursement Service. It's been a nationally coordinated quality improvement initiative supporting good practice in terms of antibiotic prescribing in community settings. A large number of GPs have been getting regular feedback on a quarterly basis about their antibiotic prescribing, and we've seen a substantial positive change in prescribing in the community settings as a result of this project. The background to this will be familiar to you. It is that, as we've heard already today, the threat of antimicrobial resistance is real, and it's here, and the HSE has a drive to reduce our antimicrobial resistance. We've heard about its global health as a global health threat, and what we're talking about is when an antibiotic that had been effective loses its effectiveness and the impact that can have on health. And acknowledging that overuse and misuse of antibiotics is part of our use of antibiotics, and that most of that antibiotic use in human health is in the community setting, this project was designed to tackle that. We've heard about ECDC data already, and Ireland has shown up as being a very high consumer of antibiotics, with community usage featuring. We know that provision of peer comparison audit data is a powerful tool in benchmarking one's own practice, and that is the mechanism that was used in this project. And it was developed a list of green or preferred antibiotics and a list of red or less preferred antibiotics to assist community prescribers in choosing better for their patients. So the aim was to support the use of these preferred or green antibiotics to drive improvements in patient safety and to improve overall the quality of antibiotic prescribing in the community. This infographic on your right shows what that looks like to the prescriber, with green at the top showing the list of preferred antibiotics in different categories. Let's see, does this work? So on the left, respiratory infections, in the middle, urinary tract infections, and on the right, skin and soft tissue infections. And on the bottom, the risks and the reasons why the antibiotics in red are less preferred, mainly relating to their risks for other harms to patients. This is a project that has had a long timeline, going back, as I mentioned already, into the era of iNap 1, when the first idea was generated to develop a green and red antibiotic list. There have been iterations over a number of quarterly issues, as you can see over time, really good engagement with our GP prescribers throughout the project, and listening to their feedback in an iterative process to improve the feedback and improve the reach of the messaging. We've used a plan, do, study, act methodology and continued to engage with those stakeholders. These are examples of the sorts of feedback that has been given and the changes made, with early issues focusing on the concept, some tips on safe use of certain antibiotics, and then as we moved into the COVID phase, this project was able to continue, but it adapted and it included use of treatments for respiratory tract infections, promotion of COVID guidelines and so forth. And the changes were all about how it looked to the reader, how it looked to the prescriber, additional explanatory notes, but really focusing on a key message for each issue. So as a prescriber, what I would receive is, on the left, a comparison of my prescribing in blue with general other prescribers in grey. And I could be able to see at a glance something that tells me how well I'm doing compared to other prescribers. And on the right, this would tell me my proportion of prescribing that in my patients compared to other patients, that was the use of green antibiotics or preferred antibiotics versus red or less preferred antibiotics. In addition, there was detail given about what were those antibiotics that were less preferred that I used, and what were they that other prescribers used, and was there any room for improvement in my practice. And what we've seen is this feedback has not only delivered measurable change and improvement in the use of these preferred or green antibiotics, but that this change has been sustained and sustained over time. And that's very pleasing, and we've seen that across a number of different metrics. We've also seen, and our colleagues in the HPSC have worked with us closely on this project, and this is a very pretty graph, but the gist of it is that the earliest data showed a broad range of prescribing quality, and that's the graph over to the left. As we move to the right, we see a narrowed range of quality and with a better proportion, a higher proportion of good practice. What we've seen is that there's been an encouraging reduction in some key antibiotics that we are concerned about, coamoxiclav, clarithromycin, and fluoroquinolones, which are concerns because of either breadth of spectrum of activity or because of their harms. And we've seen that in those three, and it's depicted in the graph too. But we don't shy away from the fact that we haven't seen reductions in this class of in the azithromycin usage. And we've sought additional information from our prescribers about why that might be, and tried to tackle that with additional supports and resources. And again, this is showing our measured outcomes. This is showing ECDC data, which shows that Ireland was one of 8 countries showing a statistically significant decrease in our trend of prescribing community. So improvement shown from a further distance, which I think is very pleasing to see. And we believe that this type of initiative is transferable to other services, certainly within human health, and we think that our next areas to think about for this are dental prescribing and acute services. But also we imagine that this could be an initiative that we could share with other sectors. So just in conclusion, and before I introduce my next colleague, this was a national initiative implemented at scale. We delivered prescriber level feedback or practice level feedback to GPs, comparing their prescribers to their peers. We nudged them towards behaviour change. And we continued to engage with our stakeholders and delivered on that cross-sectoral and multidisciplinary collaboration. We continue to have positive stakeholder engagement, and we've seen positive change in the quality of antibiotic prescribing. So I'd like to thank you for listening, and I'd now like to introduce you to our AMRIC Director of Communications, and that's Audrey Lambourn. Thanks very much.
Morning. That's the hardest part after a post-tip, getting upstairs. My name is Audrey Lambourn, and I'm the communications lead for the AMRIC programme. And I'm just going to take you through one of our main communications programme, which is Resist. Just giving you an overview of what Resist is, some of the resources that we have, just focus on a couple of the campaigns, and my screen is keep going fast, so I don't know how that's happening, but anyway. So it all started with iNap. iNap 1, and in fairness, one of the most important things was improving awareness and knowledge of antimicrobial resistance. And the Department of Health took that on board, and actually the reason I'm here today is because they put funding into that strategic objective. And that was really important. So our programme was about linking the work of our work across the HSE, taking that brand awareness, trying to get people to form part of a resistance. So we really focused on joining our superbug resistance, which was the first approach for our programme. And it really focused on hand hygiene awareness and training for healthcare workers and getting that brand out there, getting people to be part of the solution, and recognising that infection prevention control is all part of iNap and all part of antimicrobial resistance. So we broke it down into the target audiences. And this was critical for us. We focused on our key infection prevention control and antimicrobial stewardship leads that were in our services already, and mainly in our acute services, and a lot of support from our acute services. We also looked at, this wasn't just an IPC AMS issue. We wanted all of our staff to be part of that stewardship and part of that work. So it was healthcare workers from across all the systems. So we had people on our boards that were from the portering side of the house, from the catering side of the house, including the clinical people as well. The key influencers, I mean, healthcare management, were critical to this. So when we started this project off at pilot in the acute services, like our acute services colleagues here, you know, they worked with our acute services division, who then took this on board and made it nearly a directive for the hospital. So we had their support from the beginning. Every time we rolled this out into a hospital group, we had somebody from the acute hospital services management team there, because, you know, it's not just the IPC or the AMS issue, it's actually the wider full health issue. So, you know, bringing the healthcare management into it, you know, policymakers, again, we were feeding up through the Department of Health and our colleagues in the Department of Health, did a lot of work, you know, media awareness, and that all helped, and the public as well too. So a key part of the Resist programme is actually providing a wide range of materials that have been clinically approved. All of our patient materials have all gone through NALA, they've all got plain English. So we'd have all those kind of supports, leaflets, posters that, in fairness, the funding that we get actually supports that, so that oftentimes, as you know, when we do something wonderful in a service, you have the lovely posters and leaflets, you have enough for 1 year. The funding that we have ensures that we're updating our materials. We also provide a lot of communication support on some of those big awareness campaigns that happen throughout the year, like Hand Hygiene Day, Infection Control Week, and the European Antibiotics Awareness Day, which many of you will have worked on or be aware of. So we would do an awful lot of material and getting information out, so we are on one message, one brand, one set of information to all the health services. And we also share this information with our partners in private healthcare. Staff communications is a big part of the Resist programme. We have, you know, a website with all of our resources on it, and as Laura mentioned earlier, like there's an awful lot of guidance materials. I think we've done about 400 pieces of guidance in the last couple of years. We have quarterly newsletters. We're also part of the national magazine in the health service. We get 2 or 3 pages in there all the time. Again, pushing that message out. Again, trying to raise awareness, getting people to go online for our education and our online services that Josephine is going to talk about later on. But having those kind of materials that people know about, can access, can download, are all very useful to raising that awareness, improving knowledge. Our antimicrobial stewardship, I mean, Eimear mentioned already about the Red-Green project. So every year we would send out materials and letters to GPs, focusing on the public side of it, so that a key message last year was if your doctor says you don't need an antibiotic, that's okay. And talking to my colleague Adele here today, she said, like, sometimes it's really, really very hard to say no to somebody looking for an antibiotic when they're coming in with, 2 kids with snotty noses and people just want to get back to work or get the kids to school. We spend a lot of our resources on social media campaigns, and that campaign ran earlier on this year in January. And we would have had about 350,000 people looking at those videos, which, it's kind of low money, but it's a way of raising awareness around education and around knowledge of antibiotic resistance. And also the key message we're trying to tell people is how to get better without antibiotics. Our Ask the Expert was a plan that we did last year where people could actually write in or online and raise questions around antibiotics. So we targeted parents of young children here, and we would have had about 30 questions back in the hour or two that we had the window open. And we would respond directly to the questions by getting our GP at the time, Nuala O'Connor. We will be looking at that this year again too, for targeting maybe the over 65s, people that are groups that we know will be higher users of antibiotics. Our AMRIC grant initiative is a pilot initiative that we introduced in late 2021, where we are using some of our Department of Health funding to prime some projects in the services. So we awarded 12 grants, and we're just awaiting some full evaluation next month. But one of the projects there that's pictured is the Dress for AMS project in University Hospital Kerry, where all of the antimicrobial stewardship team, the pharmacy team, and some ambassadors on the nursing side were given uniforms with branding on them. They went out and worked with the teams going through SAP procedures, and it has been really it's been really important for them down in the hospital. They felt that it actually gave a very big focus on what was happening around AMS, teaching people about the new kind of SAP guidance, the surgical antibiotic prophylaxis guidance, and that buzz in the hospital has been replicated in some of the other areas locally. So we're hoping that we're going to replicate some of the successful projects in the other area, and this time next year we'll be coming back with a much bigger story on it. And hopefully, if you're in the hospitals and in years, you'll start seeing people wearing the brand, and the big thing is that once people understand the importance of their role in stewardship and in antibiotic prescribing, the evidence is there to show that it actually does have positive consequences, and I'm sure Ellen will be talking about some of that. So just looking at some of the things, it's really difficult to say in communications, 1 + 1 = 2, so that you put in certain amount of work, and this is the consequence. But we've got to have some indicators about improved awareness. So 6 out of 7 of our hospital groups have taken on this project and have run with it. And that's thanks to the support that we got from the very outset from our acute hospital colleagues. And Gwen is out there now from our community side. We had planned to run this into our community services in March 2020. A little thing called a pandemic happened. So trying to get something proactive when people are trying to survive and do their job was very difficult. So we've actually started it again this year, and in May, 3 of our community health organisations have started rolling out in long-term care residential facilities, because we know from the evidence that there is a higher level of antibiotic prescribing there. We've had 200,000 people successfully complete our RESIST education courses on PPE. The interesting thing for me is that on the annual health index, in the questionnaire, 78% of people have now answered yes correctly to antibiotics kill bacteria, which is up from 68% 4 years ago. And that's probably about 15% increase. But the big one is the number of people that correctly say that antibiotics don't work for viral illnesses. And that's gone up by about 30%, up to 65%. And you can't say that this program was directly part of that. Part of it is COVID, part of it is our prescribing education with the GPs. But everything that we do is leading towards that improved awareness and knowledge. Our hand hygiene rates are up from 90% to 93.2%. So all those little incremental changes are very important. Some of the next steps, we're going to keep working on the stewardship awareness and building on the current levels of infection and prevention and control. One of our projects we're going to be working on with the Department of Health is increasing the engagement with key stakeholders and patient advocates. So just some finishing, I just want to say thank you to everybody who's been involved, because it's not us putting together the programs and the materials, it's actually people on the ground taking it and running with it and owning it, because if you don't own it, you can't deliver on it. So thank you. I'm going to introduce my next colleague, who's Ellen Martin, who's our antimicrobial stewardship pharmacist. Thanks, Ellen.
Hi, my name is Ellen Martin and I'm Senior Antimicrobial Pharmacist with the National AMRIC team. I'm going to share with you some of the fantastic work that's been completed across the country with the aim of optimising antimicrobial use in the HSE older persons residential care facilities. So many individuals and groups have contributed to this body of work, and in particular, Bernie Love, Chief Antimicrobial Pharmacist, Community Healthcare, the CHO-based antimicrobial pharmacist, the HSE Older Person Services, and the National IPC and AMS team in Community Operations. In 2020, the very first CHO-based antimicrobial pharmacists were appointed to support the National Community Antimicrobial Stewardship Programme. And this facilitated the delivery of the first pharmacist-led national survey of antimicrobial use in the HSE older persons residential care facilities. The aim of the study was to inform the National Stewardship Programme and to provide a baseline from which to measure improvements. And all 135 residential care facilities were surveyed. 42% of these facilities had previously participated in a European-wide point prevalence survey known as the HOLT study in 2016, which allowed for some broad comparisons to be made. In the 2020-21 study, it was found that 12% of residents were on antimicrobials on the day of the survey. This is a high prevalence of antimicrobial prescribing, in comparison to the previous national prevalence of 10% and European prevalence of 5%. One really positive finding was the high usage of green or preferred antimicrobials. And in terms of adherence to prescribing guidelines, there was 69% adherence to choice of agent, 72% adherence to dosing regimen, and 37% adherence to duration of treatment. By far the most common indication for antimicrobial use was urinary tract infection, followed by respiratory tract infection. And 50% of antimicrobials in this setting were prescribed for prophylaxis or prevention of infection. This is much higher than the European average of just 29%. It was also noted that 66% of prophylactic prescriptions were prescribed for a duration in excess of 6 months. Structures and systems to support antimicrobial stewardship were also surveyed. And here are some of the key findings. 42% of facilities performed dipstick urinalysis routinely, that is, on admission or every few months, for residents who are asymptomatic of urinary tract infection. And this practice is not recommended, and it can lead to the overuse and misuse of antimicrobials. 64% of facilities had electronic access to microbiology results. A really positive finding was that all facilities offered influenza vaccination to all long-term care residents. In comparison, just 39% of facilities tracked records of pneumococcal vaccination status, and 5% reported access to education on antimicrobial stewardship. Based on this study, 5 key recommendations were made. Every resident on UTI prophylaxis in excess of 6 months should be reviewed. The practice of routine use of dipstick urinalysis for asymptomatic residents to support a diagnosis of UTI should cease. Electronic access to relevant laboratory results should be made available, and all clinical staff should be aware of national prescribing guidelines on antibioticprescribing.ie. And finally, pneumococcal vaccination status should be recorded and offered if necessary to all residents over 65. The study findings have steered the development and implementation of a range of local and national quality improvement measures. And some examples are shown on this slide. The point prevalence survey results were fed back to each individual facility directly by the CHO antimicrobial pharmacist. And this allowed for education and support to be provided and tailored as necessary. New national guidance and a suite of resources for long-term care facilities have now been published to antibioticprescribing.ie. And a national position statement on the use of dipstick urinalysis for the detection of UTI has now been published. A number of national e-learning modules have also been developed to support antimicrobial stewardship across all settings, and numerous educational webinars and events specifically targeted to residential care facilities have been delivered both locally and nationally. AMRIC are also due to publish a new antimicrobial stewardship guidance for all healthcare settings this coming month. And this document aims to provide evidence, expert guidance, and the tools needed to support stewardship across all settings. It will support the development and maturation of the existing AMS programs in the acute setting, as well as support the extension of formal AMS programs to all healthcare settings. And building on this work, standardized monthly monitoring of healthcare-associated infection, antimicrobial resistance, and antimicrobial use has been introduced into the HSE older persons residential care facilities since September. Each month, on average, 88% of facilities submit their data. And this really shows the dedication and commitment of the staff working within the residential care facilities towards tackling antimicrobial resistance. Some of this data is shown on the next slide. This graph shows the substantial and sustained positive change in the use of antimicrobials since that baseline point prevalence survey. The blue line shows that overall antibiotic use was reduced by 30%. And the orange line shows that antibiotics used for prophylaxis reduced by almost 50%. This data set also records C. difficile infection, which we know is one example of an adverse outcome associated with antibiotic use. Although it's very early in the data set, a welcome reduction in the number of C. diff cases, newly diagnosed C. diff infection cases amongst our residents has been noted. So a reduction from 14 residents in Q4 21 to 7 residents in Q1 22. Significant progress has been achieved in relation to antimicrobial stewardship in the older person residential care facilities over the last number of years. And key to this has been the collection of that rich national data. This has informed and targeted stewardship work at both the local and the national level. Another key factor contributing to the success of this body of work has been the provision of antimicrobial stewardship expertise within the CHOs. This work really highlights the positive impact that antimicrobial pharmacists can have, supporting the best use of antimicrobials in this setting. We've seen a really tangible reduction in the overall use of antimicrobials within the HSE residential care facilities. And ultimately, this reduces the risk of harm to our residents and improves patient safety. Thank you, and I'll just introduce now our Director of Nursing, Josephine Galway, who's going to share some information on the competency framework and the e-learning programme.
Good morning, everybody. So today's presentation is about sharing a summary of two of our nursing team projects. One was the development of a bespoke e-learning programme on infection prevention and control and some antimicrobial stewardship on the HSE Land platform. And the second project that we're going to talk about is the development of a core competency framework for infection prevention and control practitioners here in Ireland. So it was the first document of its kind. So who are we? So I'd like to say, as I am the Director of Nursing, but Eimear O'Donovan and Barbara Slevin work alongside me every day to, I suppose, lead out in these projects. And I'd also like to acknowledge both community and acute operations and all our infection control nurses that are on the front line here, making sure that these projects get delivered and are implemented on the ground. So without them, really, these projects wouldn't have succeeded. So I suppose as part of the strategic HSE AMRIC action plan that was developed from iNap 2, really what we're about is working towards improving patient safety outcomes, because at the end of the day, it's all about the patient and the patient safety. Improved, I suppose, staff education and training, so we have a good trained staff workforce, and improved staff safety as well, which goes without saying, and awareness and deeper understanding around infection prevention and control and AMR. So just to give you a little bit of background to our e-learning project, I suppose, as we know, infection prevention control is pivotal to patient safety and staff safety. So this development of the e-learning module supported staff and teams across healthcare to integrate IPC into a clinical practice as a standard. So our vision at the time was, and this was pre-pandemic period, was to make an accredited IPC training available that was accessible to all healthcare staff in all healthcare facilities at the time, and for all grades of staff, because infection prevention and control doesn't, irregardless of what grade you are, it's important that you have that practice in place. But obviously, it was soon recognised the requirement and the importance of IPC, that there was a standardised training programme right throughout the COVID-19 pandemic, and that was due to increased demands for training supports. So to support the training, I suppose, the vision for creating the e-learning at the time was there was needs on the ground at clinical level and with equitable access for IPC. And I suppose it was recognised there was a need for a digital platform. We needed to future-proof how we were delivering training, because infection prevention and control practitioners on the ground were quite scarce. And I suppose this programme helped to deliver training across all healthcare settings at that particular time. So it was about meeting that requirement and future-proofing. So creating these bespoke modules demonstrated in the Irish healthcare setting supported areas with a dedicated IPC resort, and also supported our infection prevention control teams on the ground in delivering education, and then that freed them up to go and do other work that needed to be done. So I suppose these circles here really are about how we planned it. In July of 19, I suppose we had the vision. Q4 of 19, we did some business case planning with our programme management team, and we got funding, and we created this AMRIC HSE Land modules. And we did a kind of a streamline and removal of a defragmented ad hoc resources. But of course, the red flag then in March 2020, here goes, we hit a pandemic. So we knew that this was, I suppose, this e-learning programme was a way of getting access to staff and making sure staff were trained right across our acute and community hospital system, and wider than that even. So these e-learning modules commenced, and in 2020, 2021, end of 2020, there was 14 bespoke modules created within 12 months. It was a mammoth task, but it was thanks to everybody on the team that got these over the line. I suppose 80,000 staff within 8 months, I think it was 7 or 8 months, actually completed the training with almost 190,000 healthcare staff accessed the accredited training course. And it was a cost of about €5 per person, so it was very lean training. That's a list of the modules there that were developed in 2020. But since then, because of the success of the programme, 8 further modules were released in December of 2020. There was 8 modules released in December 2020. There was a further 3 modules made available in September 21, and a further 3 modules available on 2022. And the programme continues, and we have a plan for 2022 that's underway at the minute. So I suppose to just to capture the practice on the ground. Was this working? Wasn't it working? Did people like it? Did they not like it? Were we able to take data from it? Were we able to pull down, were people doing it? Were people being trained? And it was a certified program. It was accredited by RCPI and also by the NMBI, our nursing accreditation body. And I suppose the learning impact we were able to draw from that, where some areas were better at doing it than other areas, both across acute and community operations. So the learning impact studies, I suppose, certainly gave us food for thought. So moving on from that, what we did was we have set up focus groups and further questionnaires of this year, and we've taken areas that had high numbers trained and areas that have low numbers trained, and we're going to look at why. Why did some areas were better than other areas? So I suppose our team delivered an IPC e-learning resource that facilitated a lean, efficient programme. It continues. I suppose the e-learning is supported, staff safety for sure on the ground, and patient safety. And a lot of these programmes can be done at home or even online yourself. So AMRIC continues to develop and grow the digital resource. There's 3 further, as I said, modules in development for 2022. So the learning impact study, I suppose, is further being progressed into focus groups. So patient and staff safety is integral, I suppose, to patient safe care. So it's important that infection prevention and control is pivotal to those roles. So I suppose that was just a fast, quick tour of the e-learning modules, but if anybody has any queries in them, they certainly can contact me afterwards. Our second bespoke project, really, that I suppose I'd like to talk a little bit about is about our core competency framework for infection prevention and control practitioners here in Ireland. It is the first document that for Ireland. It was, I suppose, a new framework, and I suppose there was a lot of extensive stakeholder engagement done for this particular document. And it was one of the actions that spilled over from iNap 1 into iNap 2. And it was work that was underway while we were in the iNap 1 period. And then when we moved into iNap 2, we fastly, I suppose, recognised that from the pandemic there was a shortage of infection prevention and control practitioners, nursing on the ground when there was needed. So the e-learning programme kind of complemented this at the time because we were able to get across a wide range of services. While we were developing this document, I suppose this document really is there. It was adapted from the World Health Organization on the core competencies for infection prevention and control practitioners, professionals. And I suppose it also took into account a number of international guidance and experience and expertise of those right across Europe and wider who contributed to the development of the document. So really this document is about supporting new infection prevention and control practitioners that are coming in to post, and it will help guide them to become competent infection prevention and control practitioners. So I suppose there's areas and domains within the document, and there's 6 areas and 13 domains. And I suppose the areas are the leadership and infection prevention and control program management, which is key, microbiology and surveillance, infection prevention and control in clinical practice, education, quality and patient safety, and infection prevention and control related to occupational health. And those, I suppose, areas are key to making sure there's a good infection prevention control program within acute and community services. So I suppose a lot of it looks at the knowledge and skills and the ability of infection prevention control practitioners. So the focus of the practitioner's attention on what they know or what the knowledge that they have, that is an essential foundation. But however, they need to be able to use what they know and their skills and ability in order to deliver on their role of infection prevention and control. So I suppose this document supports professional development, performance management, and it also supports those that are managing infection prevention and control programs and who are trying to set up teams within their either acute or community operations. So it's a guide for them to, in making good, competent practitioners. So the assessment of the competence is through self-assessment in conjunction with their line manager and professional development training. So self-assessment and the plan of action tools have been developed to support the assessment, and it's both online and in hard copy as well. So leading to professional development planning and supporting performance achievement. So this document there was a soft launch done on the 16th of May this year, and then we did a formal launch, study day for our Assistant Directors of Nursing and our lead IPCNs. That was held on the 24th of May 2022 in the Ashling Hotel, and it was opened and endorsed by our Chief Clinical Officer. So the next steps, which we're in the middle of at the moment, and that is planning a series of webinars for our infection prevention and control colleagues on the ground on trying to complete this document and further professionally develop them into roles as infection prevention and control practitioners. Thank you very much.
Thank you very much to Eimear, Ellen, Audrey and Josephine for those really interesting presentations. I'm sure you'll agree that the amount of work that's being undertaken by HSE AMRIC is incredible, so we're really grateful to you for being here today and sharing that with us. I'd also like to thank again Minister McConalogue for being present today, Minister Donnelly, Dr. Martin Blake and Rachel as well for opening up for us earlier today. So we're going to go to our coffee break now, which is just through to the left in the conservatory. We're running just 5 minutes behind, so we'll come back at 11:35, if that's okay with everyone. Thank you very much.